Welcome, everyone. Thank you so much for joining us this evening for our My IBD Learning webinar series. Tonight's webinar will be focused on navigating the cost of IBD, and we're going to hear from some expert faculty and an IBD caregiver about the following. We're going to go over some common issues and challenges related to insurance coverage for IBD medications. This will include Copay Accumulator programs and step therapy. We're going to talk about some strategies to appeal a denied claim and how to work with your provider on those appeals. And we'll also hear about some foundation advocacy updates and how to get involved as an IBD advocate. My name is Alyssa Strauss. I'm the Senior Manager of Adult Education and Resources at the Crohn's and Colitis Foundation, and I'm happy to be facilitating tonight's program. The My IBD Learning webinar series and our regional programming feature different educational topics throughout the year. This is the first national webinar in the series for the year, and we encourage you to check out our website to learn more about our upcoming monthly programs and learn about our presenters. Next slide, please. All of the presentations for this evening will be recorded and accessible to view at the completion of tonight's program. Next slide, please. I'd like to thank our sponsor, Ferring Pharmaceuticals, for sponsoring and supporting the My IBD Learning webinar series. Their support enables the foundation to continue to provide important education for patients and caregivers. Next slide. At this point, I'd like to introduce our expert faculty who will be presenting. We have with us Dr. Harry Thomas. He's an adult gastroenterologist at Austin Gastroenterology in Austin, Texas. His clinical interest is IBD, and he has served as a site principal investigator for multiple phase 1 through 4 clinical trials in Crohn's disease and ulcerative colitis. Dr. Thomas serves on the Crohn's and Colitis Foundation Austin Leadership Board, in addition to serving as the co-chair of the Patient Education Committee of the Foundation's National Scientific Advisory Committee. We also have with us Erin Bradshaw. Erin is the Chief of Mission Delivery of the Patient Advocate Foundation, or PAF, whose mission is to promote access to affordable, quality healthcare for people with chronic, debilitating, or life-threatening illnesses. In her role as Chief of Mission Delivery, Erin oversees the numerous departments that provide direct services to patients, such as all case management, Medicare line, financial aid fund programs, and patient education projects. Erin's also responsible for enforcing quality assurance, compliance of case management programs and financial services, and acts as the direct liaison between PAF and its nonprofit partners, donors, and service partners. We're also honored to have with us today Rita Deleo, who's the mom of a young adult son who was diagnosed with IBD 10 years ago. And finally, I'd like to give a warm welcome to my colleague, Sarah Buchanan. Sarah is the Director of Advocacy for the Crohn's and Colitis Foundation. She's been in this role for 6 years. She's passionate about providing a platform for the IBD community to speak up and collaborating with patients, families, and providers on public policies to improve patient access to care. I want to take a moment to thank everyone for being here today, and I'd like to pass it over to Dr. Thomas, who's going to get us started with understanding some common insurance challenges. Dr. Thomas?
Thank you, Alyssa. Appreciate that kind introduction and glad to be presenting with you all this evening. So I'm going to be discussing insurance challenges that IBD patients should be aware of. Next slide, please. I have no disclosures to report. Next slide. So we're going to be discussing 4 common insurance challenges facing IBD patients today: step therapy, copay accumulators, dosing issues, including dose escalation, and then finally transitioning from biologics to biosimilars. Next slide, please. So the first challenge is step therapy. What step therapy refers to is when your provider recommends drug A, for example, but then the insurance company says to you and your healthcare provider that you're not going to be eligible for drug A until you've tried and ultimately failed drug B and possibly drug C as well. And only then will they cover the treatment that was initially recommended for you. This is what's referred to as step therapy. Next slide, please. So step therapy is an issue because it really can affect quality of life and can delay your receiving the appropriate therapy. So it is a big issue, and it's part of the prior authorization process. Your provider, as well as you as the patient, should be notified when this happens. And the first thing to do is to contact your provider's office if you receive such a letter from your insurance company. They may be able to help you understand whether it's worth pursuing an exception or whether to proceed with the alternative recommended by your insurance company. Now, certain people are eligible to seek exceptions. If you have commercial insurance and live in a state that has passed step therapy reform, then you may be eligible to seek an exception. And it's very helpful to cite that state law in your exemption. Next slide, please. This map produced by the Crohn's and Colitis Foundation shows you the states in light blue in which these patient protections have been enacted. So you can see that actually, thanks in part to the work done by the Crohn's and Colitis Foundation, the majority of states do have step therapy reform laws in place. And you can visit the Crohn's and Colitis Foundation website to learn more about specifically what is happening in your state. Next slide. The second challenge is copay accumulators. And this is an issue that I think many of us, both patients, caregivers, and physicians, have been hearing more and more about in the last few years. Now, many people are familiar with Copay Cards. What these are awards essentially granted by the manufacturer of the particular prescription medicine that helps to offset the patient cost for that particular specialty medication, especially for patients with high deductibles and copays. Now, patients apply for the copay assistance program, and if they qualify, the drug manufacturer provides the patient with a card that is applicable toward the copay, and it involves a fixed amount of assistance for the duration of the year. Now, at the end of the day, the purpose of this is so that patients can afford the medicine and adhere to the therapy recommended by their provider. Now, what copay accumulators are mechanisms whereby the health plans make the copay assistance provided by the drug manufacturer not apply to the patient's deductible, so that at the end of the year, once the copay card has been used entirely, the patient still has a significant deductible to incur. Next slide, please. This diagram gives you an example of the copay accumulator. So it shows a patient, Julie, whose medication costs $200. Now, Julie then applies for the copay assistance program, qualifies, and then is able to pay just $25 of the total cost herself. And the remaining $175 is placed on the copay assistance card. And that gives you the total cost of the medication, $200. Now, Julie continues to use the card over the course of the year, and then at the end of the year, when the card has expired, unfortunately, in the setting of the copay accumulator, only $25 has been applied to Julie's deductible. The rest of the funds that were applied onto the copay card are not put against her deductible if she has a copay accumulator in place. And so then she is liable for the deductible, which obviously can be high given some of these newer high deductible plans. Next slide, please. So how do you know if you have a copay accumulator? You may see different kinds of language in your health insurance plan documentation. So for example, it may specifically say that coupons or other amounts from third parties are not applicable for the benefit period deductible. And these kinds of terms are most often seen in employer-sponsored plans and high-deductible health plans. And then eventually, when the assistance runs out, the patient will then need to pay more in terms of out-of-pocket expenses as the deductible has not been met. Next slide. So again, there are different state laws about copay accumulators. As of the fall of 2021, 12 states have banned copay accumulators, and these are shown in the darker blue here. So for example, Arizona, Connecticut, Virginia. And this situation is rapidly evolving. And so it is important to be aware of what's happening in your state. Next slide, please. So what can we do about copay accumulators? So you can see here that the vast majority of patients, so for example, 83% of commercially insured patients are currently subject to copay accumulators. So when you're selecting an insurance plan, it's important to be aware of this, especially if you're likely to need these specialty medicines, and consider whether you can afford the deductible and cost sharing in your health plan. If you live in a state that has not banned copay accumulators, which is the majority of the United States, contact your state's insurance department, House representative, and insurer, and also discuss with your employer. Next slide, please. We're going to move on now to discuss some dosing issues. So when your medication isn't working correctly, your IBD healthcare provider will try and adjust the amount prescribed in some settings by escalating the dose of the medicine or the frequency at which the dose is administered. And there are some situations, especially when patients have tried and failed a number of advanced therapies, that some off-label medications may be recommended. Next slide, please. So frequently, your provider will recommend dose optimization or escalation or some off-label medication, and it might be denied by your health insurance company. So what do you do in that situation? You have the right to an appeal, request to review the decision that's been made. Obviously, speak with your doctor, ask them to write an appeal letter. And the Crohn's and Colitis Foundation has a number of really high quality sample appeal letters, which can form the basis of the appeal letter in your case with your specific situation included. Then pay attention to the guidelines and rules administered by your insurance company. Send along all the necessary supportive documentation. That can be a big issue. Sometimes things will be denied for relatively trivial reasons because the appropriate documentation wasn't included with the appeal, which can be quite frustrating. And then confirm that your insurance company has received the appeal. Next slide, please. So moving on now to the fourth and final challenge that I'll discuss today, transitioning from biologics to biosimilars. So what are biosimilars? These are biologic therapies that are highly similar to the brand name biologic. In the United States right now, the main biosimilars that we're seeing are for infliximab, shown here. And in other countries, and soon in the United States, we'll be seeing this also for adalimumab, for example. Now, many people will know that many insurance plans are no longer covering the name brand biologic in the first instance, and they're mandating that patients switch to one of these biosimilars. Next slide, please. So if you receive a letter indicating that your insurance company is mandating a switch, first of all, contact your healthcare provider, as it may be subject to a prior authorization. Ask them whether that switch is right for you or whether they feel that you might not be a suitable candidate for transitioning to a biosimilar. Now, the Crohn's and Colitis Foundation does support a single switch from a biologic to a biosimilar or from one biosimilar to another biosimilar if you are in remission. And that last point is very important. There are situations when a patient is not in remission or needs a dose optimization, for example. And those are situations which really aren't ideal times for patients to be switching to a biosimilar. You can find more information about biosimilars at the Crohn's and Colitis Foundation website listed below. Next slide, please. So the take-home messages are that these 4 issues, step therapy, copay accumulators, dosing optimization, and biosimilars, are some of the most common medical and financial challenges that patients with Crohn's and colitis may encounter with their chronic disease. If you're presented with any of these challenges, first discuss it with your healthcare provider, speak with your insurance company. Many of these companies do have patient navigators, which can be helpful for patients with chronic diseases such as IBD. And then also reach out to the Crohn's and Colitis Foundation, which has a lot of great resources, including the IBD Help Center, which can be reached at this number, 1-888-MY-GUT-PAIN. And then learn more on the Foundation's website about some of these cost-saving opportunities and view some of the sample appeal letter templates, for example. And the website is given here below. So thank you all for your attention. And with that, I'm now going to pass the reins on to Erin Bradshaw.
Thank you, Dr. Thomas. So it's a pleasure to be here today and share more tips on how to handle a denied claim. We learned a lot just with the common issues that you're facing, and Patient Advocate Foundation has been providing support for 25 years, helping people navigate and guide through these challenges around health insurance, benefit design, and denials and appeals, in addition to helping locate resources to help pay for treatment and daily cost of living. So with that being said, let's get started and go to the next slide, please. So I feel like it's important for us to talk about some major topics. And one of them is not everything is always appealable. And so we need to decipher the difference between when a claim isn't paid, as well as common reasons. I'm going to cover balanced billing, or what is known today as the Surprise Billing Act, the appeal process, and tips to yield some good outcomes for you. Next slide. So it's easy to assume that the lack of payment is an indicator of a denied claim, when that's not always the case. And not all unpaid claims are a representation of an insurance denial. And why this is important is that you don't want to initiate an appeal process or make the assumption of such, but without further investigating it, because you might be investing time or energy that might not represent an outcome that you were hopeful for. So some of those reasons might be your share cost responsibility, such as deductible. Or if a claim is not fully paid for, it could be a co-insurance or co-payment responsibility. But there also could be a billing code error, where your provider might have submitted something that was not processed correctly. They might need additional documentation to support the additional payment towards it. Or sometimes the insurance company is not billed correctly. So they might have an old record of another insurer, or accidentally transpose a number and it doesn't get sent correctly. So be certain to tease out this important information, because it will help you avoid unnecessary submissions and time invested. And it might be a simple resubmission or request, or even finding an alternative resource if it's a share of cost. Next slide. So after you've concluded that you do indeed have a true denial, the first step is to investigate the denial and the reason for it. So on this slide, I've identified the top areas of reasons for denial that we at the organization at Patient Advocate Foundation has seen. And as you can see, it does cover those that Dr. Thomas had shared as well. And If it's not clear to you why, you need to learn more by either evaluating your explanation of benefits, also known as the EOB, or it will come through a denial letter. A good rule of thumb is if a service has already been received, that denial information will be on your explanation of benefit from your insurance company. If the service or medication or treatment has not been, whether it's a prior authorization or you're seeking that care, it will likely be on a prior authorization or a particular denial that will give you that reason. So as you look at this chart and you see these variables, there's importance to it, as shared earlier, about why and how we're going to be using this information to be supportive to your appeal. I'm going to shift focus to specifically the topic of out of network, as it leads directly into the balance billing aspect. Next slide, please. So depending on the plan benefit design that your insurance is, they may pay less or not at all if services are outside the network. And really a network is just an accumulation of providers and facilities and where they have negotiated a contract payment, and you have to stay within that network to gain the benefits within that design. It's always best to stay within your network, but there are circumstances that will not present, and that case will be there, whether you need a specialist that isn't available in your network, or in situations like an emergency when the patient is unknowingly or involuntarily treated at a facility or provider that's out of network. In a non-emergency, you might be going to a network hospital or doctor, but maybe there is an out-of-network provider, such as a radiologist or an anesthesiologist, that wasn't aware, and you might be subject to those bills. The other area that you'll notice it is ambulance services, whether air or ground. And surprise bills are just a bill that the insurer patient receives after they're unknowingly or involuntarily receiving this care that I just shared, and the outside, and then the insurance company is paid what they classify as the out-of-network coverage, and the practice is balance billing you. So they're billing you the difference between the insurance negotiated rate and what was billed for, and that's what balance billing is. So this slide here is an indication of two different examples of how that is representative and how that traditionally is defined. Next slide. So the good news is, starting in January 1st, 2022, the No Surprises Act was applied to patients who get health insurance through employers or the health insurance marketplace, healthcare.gov, that you might be familiar with, the Affordable Care Act, or an individual health plan purchased directly from an insurance company. So patients who have Medicare or Medicaid or other public insurance have always been protected under certain surprise billing practices, but this particular law was enacted to provide a federal state support. What's important to really emphasize here in this chart is kind of give you an indication of how this is being determined and evaluated and how it's classified. But the importance that I want to emphasize for you all is that No Surprises Act protects patients from being held responsible for paying for surprises or balance billed more than the network cost sharing. However, it is the responsibility of the patient who receives these surprise bills to evaluate them and bring those to the attention of the provider should you recognize that you're getting billed for the differences. So I recommend that you delay before you pay. It's really worth comparing, your explanation of benefits to the bills, ensuring that indeed they're following these best practices. And if you're having challenges, there's a No Surprises help desk information at the bottom of this slide where you can report the situation and call the hotline for aid. Specifically, this law is intended to protect the insured that are receiving care in the emergency room, emergency transportation by air ambulance, but unfortunately it does not cover ground ambulance, care received in the hospital following an emergency visit, known as post-stabilization services, non-emergency care related to an in-network hospital or facility by an out-of-network provider, and I shared earlier, like a common anesthesiologist or such like that. Next slide. So as you are now learning what it is that you're appealing, I'm going to put some more emphasis on what Dr. Thomas shared earlier. It's important to, once you've determined that, to be succinct and factual. You need to determine who is going to support you in the appeal, who's going to be submitting it, but very importantly, pay attention to timelines. Your denial or explanation benefit will clearly define, any type of timeline that you must follow if you disagree with the decision. It'll also give you guidance on where to send that information and where it's going to be sent. And you want to be contacting your provider for support. They're a huge advocate for you when you're trying to contest something based on the nature of what it is. In addition, a letter of support, whether that's written by the provider or you're writing it with addition of other people, but try to be very factual, try to take the emotions out of it, as difficult as that is, because you're placing an argument around a contractual dispute. And so if you can stay organized, put together a very comprehensive but detailed letter and attach information that's relevant to support your claim. So that might be journals or letters of support or medical documentation from your charting that can support that. And so the example, when they were talking about step therapy and trying to get a coverage for a particular medication, if you have tried medication in the past, but maybe that's not obvious because the insurer is new to you, that might be something that you have to provide in order for that to be approved. Or you can have other elements such as that. Next slide. So just a re-emphasis of what you need to include in the appeal. It's better to provide limited but important information than to provide vast. And what you want to do in your letter as you're pulling it together is you want to put you want to pull out specific information of anything that you're attaching to draw the reader to specifically what you might be saying. Because if you're attaching a journal article and there's a particular reference in there that you want to spell out, or maybe a note within a medical chart, you want to provide that detail as much as possible, and then the supportive information in addition for the reviewer to look at both, but to make it very easy and understood and document as well. And then of course, it is usually in your best interest to find out how they will see that information. A lot of people can upload now and fax, but if you do have to mail it, I highly recommend that you mail some certification with signature, and you always follow up to acknowledge receipt. Next slide. So there are some variables depending on the type of insurance that you have. So the next 3 slides are going to talk about the different insurance companies and how you might go about this. And so from a high level perspective, with commercial insurance, you're going to have 2 types of appeal options. You're going to have an internal and an external appeal. Almost always your insurance is you're going to do an internal appeal, which is requesting a review and of a benefit from a denial that's done by your insurer. And then as it progresses, if they disagree with you and you continue to go down that path, you have an opportunity for an external review. The post-service care has more limited levels of appeal, and the external appeals must be requested in certain timelines. So again, just going back to paying attention to the denial letter or the explanation of benefit, it will give you clear, identifiable information. The insurance plan should as well, and you can also follow up with the insurer through the phone or your employer. If you have a situation that is urgent or classified as imminent or life or death, you do have the right to request an expedited appeal. And that is something where you're validating that this indeed needs to be reviewed within a 72-hour period to give you opportunity for a quick decision, so that you're not waiting, which could vary to like 30 to 60 days, depending on where you are in the level of appeal, which is a long time for certain treatments and protocols. So your employer is a great resource. If you have health insurance through your employer, you can contact the Human Resources Department on how to advise. You can contact state to help. The consumer assistance programs, or CAPS as they're known, offer direct assistance as well, and they can guide you through the process. And you can also look at healthcare.gov or cms.gov with connecting to state resources. And of course, there's advocates like Patient Advocate Foundation and and organizations that we're sharing today. So please don't feel like you're going at this alone. Just know that there are elements and there are very guided protocols. You just want to stay within them so you don't miss out the opportunity to contest something you disagree with. Next slide. So Medicare, the process of appealing is very similar to commercial plans, although the wording is different. The appeal process will be different as well, depending on what kind of part you're talking about. So Medicare has Part A, hospital insurance, Part B, medical and outpatient insurance, Part C, which is an Advantage plan, and Part D, prescription drug plan. You can get assistance from your state health insurance assistance programs, also known as the SHIP programs. They offer free services for people to help navigate these questions. A lot of times you're going to learn that, of a denial or a lack of payment through the Medicare summary notice. So that's similar to what we would call an explanation of benefit in the commercial plans. But that provides your services and supplies that were billed to you during a 3-month period. And that's what's Medicare's paid with the max amount of then. And so pay attention to those things when they come to you and really compare them again to your bills. You might see it as well if a provider specifically tells you. It's important to note that very few services require prior authorization in traditional Medicare. So almost all appeals you'll see are for Part A and Part B post-service. The last page of your medical summary notice, MSN, what they will call, will give you a step-by-step directions on when and how to appeal. There are 5 levels, and you have the right, and there's some guidelines associated to each. Next slide, please. So with Medicaid, the state requires, we're requiring a process for each state for every member to appeal. And the rights are established federally. However, every state has individual rules in processing the appeals, just like the guidelines for qualifying for the program. So while they require to offer a fair hearing, it's important for you to investigate how your state handles that in particular and approach these in that way. And keep in mind that if the Medicaid program is administered under a managed care organization or an HMO type plan, that there are going to be different guidelines to follow well. So the best guidance I can give is that when you're denied service, they should be sending you a written notice called a notice of action to a beneficiary. So you need to follow those strict specific guidelines and navigate through them. Some have verbal, sometimes have written. I think a writing an appeal is best because there's documented evidence to go back to, and you can provide supportive information. Next slide, please. So there are some helpful resources that Patient Advocate Foundation has put together. We have an appeals guide, but we also have a training session that's a module where you can learn about appealing and become your own advocate for yourself or for others, and really dives much deeper than what we're talking about today in the limited time we have together. And of course, case management is always available for you if you have some additional support needs and really like individualized support above and beyond some of the resources that we shared in addition. Next slide. So I do get this question asked a lot from the organization as well. What happens when I've exhausted all my appeal rights? And really, it's going to depend on the type of plan that you have. Because traditionally speaking, once you've gone through all levels of appeal, you have in essence exhausted your rights to appeal, and there are no further opportunities for you to contest those charges. However, if you find that your employer is self-funded and they are making the decisions on payment of your plan, then you can, if you choose to disclose your health information with your employer, request that they consider a compassionate appeal, and you can triage that request directly to top executives of the company and ask them to make a final decision and approve your treatment based on your arguments. In addition, you can reach out to elected officials, file a complaint with the State Department of Insurance, or contact the media. The outcomes vary depending on those situations. And then we always evaluate different plan options. So depending on what is the reasoning for denial and the challenges that you're facing, electing a different plan, benefit design or coverage could be an alternative to trying to fight through a battle of getting coverage to expand your benefits during open enrollment or a special enrollment opportunity. And I always encourage that no matter how happy you are with your plan, you should always take this time to evaluate your plan for the coming year during open enrollment because things change and they don't always stay the same, as well as your healthcare and your support needs might as well. And then, of course, applying for patient assistance for any prescribed medication or charity care at a hospital or facility. If you can show evidence of support of appealing and trying to get access to a medication, that you might qualify for a manufacturer's free drug program, and that might be an alternative way to get access if you're unable to be successful through the appeal process. And next slide.
Thank you so much, Erin. Thank you. And thank you, Dr. Thomas, for those very engaging presentations. I'm excited now to introduce to you Rita Deleo. She's an IBD caregiver, and she's going to share with you a little bit about her personal story in navigating the cost of her son's IBD care. So thank you, Rita.
You are welcome. Thank you so much, Alyssa. It is my privilege to share part of our journey with you, with the sincere hope that it helps you navigate your treatment plan. I honestly had no idea what IBD was when my child was diagnosed. The level of suffering and heartbreak that we would be confronted with was unimaginable. At the time of diagnosis, we were introduced to the step therapy process. And as each medication failed, the personal challenges of the disease, coupled with the insurance denials and subsequent delays, were very difficult. The nurse or the appropriate staff at the doctor's office, while they could submit the order or the medication treatment that the doctor wanted, they could not approve it. As my son became sicker, I became desperate. I wanted to find someone who could help us with the insurance process. There was a learning curve and a number of steps just to get the medication that could potentially help my child stop bleeding. After repeated calls to the insurance, I was connected with a case manager. Some insurances refer to them as a nurse manager, as you've heard in prior presentations. And please check with your insurance if you have not done so, because this individual is instrumental in helping you navigate the process. The woman we connected with was truly an angel. And fortunately, she is still with the company. She hasn't left or retired. So there is a familiarity with our case. She's instrumental in keeping us informed. And I have learned several steps in navigating what the process our insurance follows with the denials that we see. Denials are difficult. And as you know, most importantly, they delay treatment. Every medication that we have been prescribed over the last decade was met with a denial before we got an approval. The importance of this nurse navigator is best illustrated by this example. Several years ago, my son was prescribed a medication that caused a severe reaction. It had to be discontinued. Recently, he had to change medications again, and he was very sick. And after dealing with the denials over all these years, I knew an approval was not likely. When I reached out to the nurse navigator, I was proactive, said that the doctor's office was going to be sending this new order. She immediately informed me that it was not going to be approved, simply because it did not follow the treatment plan that the insurance had in place. And Dr. Thomas did review this in his presentation, that that's common. However, the medication that they were requiring had the potential to cause the same type of reaction that we had seen early on in my son's treatment plan. The nurse had at the insurance company, the nurse navigator had told us to request a peer-to-peer review. And in the previous presentation that Erin just gave, you heard about the peer-to-peer review, the doctor-to-doctor review that has to be done within the 72 hours. And physician's office is your advocate. I reached out to them. I updated them on what was happening with the insurance, and they did request the peer-to-peer review. The call to the nurse navigator expedited the entire process. She was able to connect directly to the pharmacist at the insurance company and document everything that I was telling her before the peer-to-peer even occurred. So the prior records that were on file about his medication reaction were able to be pulled. It avoided the waiting for the denial to come in the mail, but it truly expedited the process. the challenges have regarding the cost and the copays and it's monumental, and the prior presentations have done such a great job in detail. So I don't want to, try to even, explain to you some of the challenges with our insurance. However, one of the things I will point out is that our insurance does require us to use a third party for all medications to be shipped to us. So if you're dealing with medications that are being shipped, my one thing that I would say to you is make sure that there are enough refills on file with that carrier. Make sure that they give you a tracking number when they are shipping the medications, and that a process is in place for delivery. The key relationships and contacts are priceless in navigating this entire process and system to receive the treatment that our doctors are requesting and that the patients need. The doctor's office staff, the insurance carrier, and also the infusion center. If there's infusions that are being administered, they also require approval in addition to the medication to have their services be paid for. I hope all of these points regarding the relationships, and really it's so important that we speak up and that we ask for help and develop the relationships that we need. And there's so many resources out there, whether it's the Crohn's and Colitis Foundation, the people that you were introduced to tonight. I hope that you reach out to them if you do need them, because the resources are there to help us. Thank you. I'll turn it back over to you, Alicia.
Thank you so much, Rita. I'm excited now to share with you the final presentation, and that's from Sarah Buchanan. And she's the Foundation's Director of Advocacy, and she's going to provide some updates for you about our advocacy priorities. So Sarah, take it away.
Great, thanks so much, Alyssa. Next slide, please. So for my presentation, I'm going to cover how public policies impact access to care, some of the key public policies that the Foundation advocates for, and how to get involved with us in advocacy. Next slide. I thought Harry and Erin both had really great presentations that cited these laws, so I was excited because that made my job easy. The bottom line for this slide is that public policies do impact access to care. Each of these images represent a law that's passed in recent history, from the Affordable Care Act, which passed in 2010 and enacted key patient protections for individuals with pre-existing conditions, to the No Surprises Act, which passed in 2020 and ideally in the right, which holds patients harmless from surprise bills when the provider and the health plan disagree on reimbursements. The map on the right side of the screen shows which states have passed state-based step therapy reform laws. Over 30 states have passed them. They're indicated in light blue on this map, and we'll cover that later in this slide. Because public policies do impact IBD patient access to care, it is a strategic objective for the Crohn's and Colitis Foundation to be involved in advocacy. Next slide, please. The Foundation advocates for both medical research funding as well as improved access to care. Our access to care priorities are listed on this slide. They're step therapy reform, as well as medical nutrition coverage. As I mentioned, over 30 states have passed step therapy reform laws, and we're hopeful to pass them in all 50 states. We're also pursuing passage of the Safe Step Act in Congress. For medical nutrition coverage, there's currently no state-based initiative that we're involved in, but we are trying to pass the Medical Nutrition Equity Act in Congress, and I'll cover both of these initiatives. Next slide, please. Harry already covered what insurance mandated step therapy is, so this probably sounds familiar. That step therapy is when a health plan requires patients to try and fail on one or more insurer preferred treatments before the plan will agree to cover the treatment initially selected by the patient and their provider. The state laws and the federal Safe Step Act are very similar. They're based off the same model legislation. So while state laws do vary from state to state, in general, the step therapy reform laws would do three things. They ensure that plans offer a step therapy exceptions process. They establish circumstances when an exception request should be granted, and they require plans to respond to a step therapy exceptions request within 24 to 72 hours. Basically, these step therapy reform laws would make it so that patients have access to an expedient and medically reasonable exceptions process when they're subject to inappropriate step therapy. Next slide, please. As I mentioned, over 30 states have passed these laws, which is a really good news story, and we're hoping to pass them in the rest of the country. It is very important to the foundation to raise awareness of these laws and provide resources so that if a patient is subject to a medically inappropriate step therapy protocol, they're aware that they have protections and they know what to do. If you visit our website, crohnscolitisfoundation.org/step therapy, you can get to a interactive version of the map, and you can see which states, whether your state has passed a step therapy law or not. Click on the state, and then you can see details of that specific law, as well as an infographic like the one on this slide that shows or provides some advice on what to do and how to request an exception request, how to request an exception if you believe that step therapy protocol is medically inappropriate. Next slide, please. The other public policy priority is trying to get coverage for medical foods. We're specifically seeking the passage of the Medical Nutrition Equity Act, which is in Congress, and it would require that all plans cover medical foods, including for patients with Crohn's disease and ulcerative colitis. Medical foods, as many of you know, include parenteral and enteral nutrition, which is an important treatment option for patients with IBD, and especially in America, a popular treatment option for pediatric patients. Unfortunately, medical foods are often not covered, which means that patients and families are forced to opt for a different kind of treatment that is covered, but maybe less ideal for that patient. That's why we're trying to seek the passage of the Medical Nutrition Equity Act to make sure that all plans cover medical foods and that patients have access to this important treatment option. Next slide, please. To summarize, the foundation hopes to pass step therapy reform laws in all states. We're also trying to pass the Safe Step Act in Congress, as well as the Medical Nutrition Equity Act in Congress. We hope that you will join us in advocacy. You can join us by signing up for the Advocacy Network at www.crohnscolitisfoundation.org/advocacy. If you sign up for the network, we'll provide you with monthly updates. We'll also send you notifications on when to take action, and we'll provide sample messages to make it easy for you to email your legislators or call them. Lastly, we'll provide you with some advocacy tips and training, including some tips on how to share your IBD story. Really, all the public policy advancements that have been made to improve the lives of patients were made because patients like you spoke up and shared your story. It's truly so important to connect your story with the public policy issue and explain to legislators how it impacts real people in their home states and districts. So I hope you'll join us and sign up for the Advocacy Network. And with that, I'll pass it back to Alyssa.
Thank you so much, Sarah. Thank you again to all of our presenters for your talks tonight, and for Rita for sharing your story. At this point, I'd like to have everyone back on. We're going to do a little bit of a Q&A with all of our panelists. So if everyone can get off mute, that would be fantastic. So we'll just do a few commonly asked questions. I'm going to start off. Harry, I know you talked a little bit with us about copay accumulators, and I know, Sarah, you're familiar with this issue from the advocacy side. You told us a little bit about the language that the patient might see. And I guess my question is, do they find out right away that they have the copay accumulator program, or does it typically happen after they go ahead and submit their card to get the medication?
That's a good question. I think that for some people, it probably is a surprise if they weren't aware of their plan details ahead of time, and then they may only come to really appreciate what it means when the card funds have all been used and they find that their deductible has not yet been met, and that they are then liable to the costs. Sarah? anything
Yeah, thanks. So the foundation and our wonderful IBD Help Center fields many calls from patients, and what we hear often from patients for whom it was a total shock. And these are patients with high deductible health plans. So not only was it a shock that their copay assistance card didn't apply to their deductible, but it also left them on the hook for, you know, maybe thousands of dollars for their care that many patients just can't afford. What we found is, you know, I think typically the small print that Harry provided in his slides were great. You know, it's great to be able to try to look through your plan materials and see if that, you know, fine language is in there. What I've seen, where I'm curious what Erin thinks on what can be done if a patient is subject to a copay accumulator. Some, you know, one-off stories I've heard is that patients were able to, you know, have the copay accumulator program waived just for that plan year if that, you know, fine print language was not actually included in their plan materials at the start of the plan year or when they bought the plan. So that transparency piece is really important to insurance regulators, and that can weigh in your favor if that transparency was not there when you realized that you were subject to a copay accumulator program. Erin, I'll pass it to you to see if you have anything else to add.
Absolutely, and that's why the review of your contract is so important, because you should not take what is said as truth, and that is what you're trying to do. You're trying to find those loopholes or opportunities within the plan that might contradict or be missing as your argument standpoint, especially when you're talking about something like this that is a very defined measure of process that's established of you know, exclusion element. And so, you know, that's sometimes it's sent in letter form, sometimes it's updated, but, you know, I like Sarah said, that is what you're looking for too.
Thank you.
Mm-hmm.
So my next question is to Harry, and this goes back to what you were talking about transitioning from biologics to biosimilars, and that's definitely a new emerging area that's many patients are facing. So, you know, we hear about appeals, right? So can patients appeal to not switch? And have you seen a successful appeal? And what do you as a physician advise your patients who are trying to navigate this when they get that letter in the mail?
Yes, this is an important issue, and it's changing with time. The current situation is that it's very difficult to appeal for some of the insurance companies that are mandating biosimilars. Sometimes the only time they'll really allow the originator biologic is if you do try the biosimilar for some period of time and, you know, perhaps have an adverse reaction to it, and then to go back to them and say that, you know, this was the issue. We're now really asking for the originator biologic. In those instances, there, you know, can be success, but otherwise, they're becoming more and more stringent, and we're generally finding that even the appeal letters for patients in stable remission are unfortunately not very successful right now. Now, that being said, I will say that it is important to be sure why they are not approving the decision. Just today, in fact, I had a situation where I had a patient on the originator infliximab. I was requesting an increase in the dose of the medicine because the patient had not achieved adequate remission, their drug levels were low. We put in the request, and I was surprised to find that the request was denied because it really was a straightforward request. You know, few physicians would have kind of doubted why we requested that. I had the peer-to-peer conversation just this afternoon before this webinar and came to find out that they denied it because they were trying to switch the patient to the biosimilar. But I explained the situation. The patient wasn't doing well, was not in remission. They had low levels. We not only didn't want to switch to the biosimilar, but we were actually trying to increase the dose of the originator biologic. And when they heard the situation, they actually agreed quite rapidly that it was the appropriate thing to do and overturned their denial. So in the situations where there's been a clear misunderstanding on the part of the insurance company, then there can be success. But for a patient in stable remission, it can be hard now to argue to maintain on the originator biologic.
I'll add that the foundation has a biosimilars position statement that was written by several committees of our National Scientific Advisory Committee. And many of our providers have been tracking the rise of biosimilars in the treatment paradigm and feel absolutely comfortable with patients switching from the originator to the biosimilar, per Harry's point, when they're stable. So we do always encourage patients to talk to their providers, but rest assured, I know biosimilars sound really scary, but I think it should be a pretty comfortable switch, hopefully. And the foundation has a lot of education materials on our webpage where you can learn more.
Thank you both. So now, Erin, a question for you. You gave a lot of great information about submitting an appeal, and you covered, all the things that you really should include in that appeal package. Can you maybe highlight for us like the most important things you should include? And you also talked about email and snail mail, and I'm just curious if there's a preferred way to go, or if you do both.
So it's going to be dependent on the insurer's preference or how they accept information. Obviously, if you can submit it electronically, it's efficient. It's attached. You can kind of see it, and it's it gives you a little more faith of it getting there timely. Mailed information tends to take a little more processing time. You're also having to print documents together and package them up and pay for overnighting and things of that nature. So, but again, you can't assume that they're always going to accept it that way. So I would say that if you have options, from a technology standpoint, it's always better. But if not, to put together opportunity, always keep copy of everything that you've sent. That's my big element of it. The appeal letter is your argument and what you're trying to contest or make as your statement of why you disagree with the position that they've taken. And so your facts, what they've said they've denied it on, and what you're making and contesting with. So attachments like journal articles or letters of medical necessity or support from your providers, charting of that is supportive of what you're trying to argue. So with step therapy, you might want to be showing that you've tried other medications or you've had adverse reactions to certain things. If you have a network, maybe your in-network director is supporting the fact that you need to go out of network because there is no adequate specialist, et cetera, to support you. So it is very specific to the particular target and why you're being denied. And you might find a combination of a couple of them sometimes. You might find an investigational experimental medical necessity with a combination of out of network or it's that nature. And so pay attention because that is what you're trying to do. Attach the denial letter or explanation of benefit in addition. So keep in mind that in the different levels of appeal, different people are going to lay eyes on these types of things. So having a very comprehensive, organized packet is important too. And right down to identifying in your letter exactly which attachment that you're speaking of, make it easy because that is, that's kind of key too, trying to drive them to that. And so those are, your big targets. There are certain insurers that do require you to have a specific insurance company form. They might have their own appeal form they need you to submit with it. If you have an appointed representative that's working on your behalf. You might have to have another form of authorization to do that information. So those are other key elements that if they're missing could cause a delay or a kickback in the appeal. So just read, what it is. Again, you have a lot of assets on our webinar today, as well as just resources out there too, if it gets really overwhelming.
Thank you.
Yes.
And Rita, I'd love to finish our Q&A with you. As a parent, what are some of your tips in working with your provider and in sort of managing all that correspondence with the insurance companies? I'd love to hear, your perspective and what you think would be most powerful.
What Erin just said, the fact of keeping copies, I keep copies of everything. I mean, even whatever orders, whatever results, like every single thing, I have it in a binder, anything that can be forwarded, because carriers, unfortunately, all of our EMRs aren't connected. And so where you have results, say, one hospital, they may not be able to show up at your primary caregiver's office or GI specialist. I mean, we had an incident recently where I had to take my son, we were out of state, and I had to take him to a hospital, and those EMRs don't connect. So if I didn't have the records and know the history, there would have been so many things that either would have been done unnecessarily, or treatment would have been delayed. So those, what Erin said, absolutely keep the records 1,000%. Some of the other things, though, when I say about the relationships, the specialist office is obviously key. They know the patient, they're prescribing the medication. And so often, and as I listen to Dr. Thomas talk, even with what he experienced today, the frustration, like the time it takes for the physician or their staff to interact with these insurances takes time away from what they can do with their patients. And that to me is infuriating, even that they have to do the peer-to-peer. When their order, they already are educated, their order should be enough, and it's not. So what I have found, that relationship with the doctor's office is key for another reason. So often, and I believe the doctor's office when they said they sent the documents, the charts, whatever, and somehow, and I don't know how, they don't reach the party they're supposed to reach. So having that connection with the insurance company and the infusion center, which is another key, because not everybody's doing an injection at home or taking, a medication by mouth. It might be that they have to go to the infusion center, and that is yet another approval process. So you have the physician's office, whether they're sending it by two places, the infusion center as well as the insurance. Both people need these documents. So you do need to be in contact and have, whether it's the nurse, whether it's their insurance, individual at those sites that, everybody kind of depending on their staffing has a different either title or person that handles this, but getting to know who they are, and that, face to face, when you can have that interaction with the people is great. But unfortunately, that's not always possible with the insurance company specifically, but also our insurance company. And this is something, if I leave one tip, this is so important. The insurance company, we have our insurance, requires us to use a third party out of state for medications. And this is a real challenge because some of the medications have to be shipped overnight and have to be kept at a certain temperature. And for me, that's like totally out of my control. It's not like I can go to the pharmacy and pick it up or go to the doctor's office and know that it was handled appropriately. You are taking it from a third party, and granted, the pharmacist at that site is packaging it, doing everything according to whatever the manufacturer says. But now they're handing it off to whatever the carrier is. It FedEx? Is it UPS? The Postal Service? Whatever party that is, that then has to take it and ship it to the patient. And there's a lot of steps in that process that could go wrong. And I've seen a number of them that have occurred with us, where there's a major snowstorm on the East Coast and that carrier can't deliver. Well, what happens with that medication? Well, apparently they have intermediaries that pick it up and store it. Well, do they know the processes of this particular medication? And when it is delivered, again, going back to the thing that it has to be at a certain temperature, in specific situations, the carrier delivering it has left it on the porch, at the front desk, or, where my son was living at one point, we were in an apartment, like leaving it outside the building. I didn't even know it was there. And if it's not at the right temperature, it could get contaminated, obviously. The third party that ships this, when I called to order the medication, they go through this whole script, and two of the things that they say is this is non-returnable and it's non-refundable. And that, for a whole host of reasons, is upsetting, because through the whole process, we as the patient or caregiver have no control over it until it's in our hands. So what I suggest to any patient that has to use that third party and have insurance or medication shipped is to have a tracking number, but have a signature requested. So it's being delivered into your hands or to somebody that you know can be there to pick it up, because otherwise the carrier's delivering it. They're going to say they delivered it. And I have gone through so many different appeals outside of the healthcare system with these carriers to try and track our medication. So I would go back to the key relationships, the doctor's office, the insurance, the infusion center, but also knowing the process with and where you're getting your medication from, if it is being shipped in that way.
Thank you so much for sharing your story. We're going to conclude now. So thank you all for being here, Sarah, Rita, Erin, Dr. Thomas. We're very appreciative of your time. We want to thank our sponsor, Ferring Pharmaceuticals, for their support. And we want to thank you all and have a great evening.